mine. And while she's doing that, I'll take the opportunity to introduce Dr. Kathleen Navarro. It's a real treat because she's a real expert and nice to work with. She's a research industrial hygienist with the Center for Disease Control, National Institute for Occupational Safety and Health. That's what NIOSH stands for. And she's worked with wildland firefighter health and smoke research for the last 6 years, working in close contact with the U.S. Forest Service Region 5 on air quality, the National Technology and Development Program. And last season, she was actually a crew member on the Redmond Hotshots. And I think that's an example of putting these things together. That's really impressive to be able to go out with the Hotshots who, that's hard work, and also maintain the kind of research program she does. So Kat, we just went to your presenter view. We had it up as a single slide before, but maybe you can go back to the other view in PowerPoint. And so Dr. Navarro has been supporting the U.S. Forest Service and Department of Interior since March on their COVID-19 response. She's a member of the Interagency Wildland Fire Medical and Public Health Advisory Team. I guess you pronounce it MFAT. She received her master's in public health and PhD from the University of California, Berkeley. So really pleased to have Dr. Navarro, and I won't take up any more time, but turn it over to you.
Yeah, is that view better?
Yes, thank you. It looks good. And we can, thank you.
Thanks, and thanks for the introduction. So I'll be starting today by giving an overview of coronavirus disease 2019, COVID-19, and then going into some of the guidance that we at CDC have created and with our interagency partners through a wildland firefighter FAQ, which I'm sure most of you have seen on the web. So information in this webinar presentation is not exhaustive, but meant to be an overview. So for full kind of more in-depth knowledge, I recommend everyone go check out that FAQ page. And our page was updated last month, and we're working through a few more updates this month as well. So stay tuned for those. So just a brief introduction, SARS-CoV-2 virus, which causes COVID-19, was identified in Wuhan, China in December 2019. Early on, many infected individuals were reported to have links to large seafood and live animal markets. Later on, there were individuals who were not linked to these markets, so we indicated a person-to-person spread, and the first travel-related case was seen here in the US in late January. So the virus is thought to spread mainly from person to person, especially between people who are in close contact with one another, about 6 feet in distance. So this is through respiratory droplets, which are produced when an infected person coughs, sneezes, or talks. These droplets then can land in the mouth of other individuals or noses. Nearby individuals who are pre-symptomatic or they just start showing symptoms, but possibly infected individuals as well who remain asymptomatic throughout their entire infection. So the virus that causes COVID-19 is spread very easily and sustainably between people, more efficiently than influenza, so the flu virus, but not as efficiently as measles, which is highly contagious. So the virus can also be spread possibly through people who touch infected surfaces. So virus lands on an object, then someone touches it, then goes and touches their mouth, nose, and possibly their eyes. That's not generally thought to be the main way it spreads, but we're still learning how it spreads, and that remains a concern for virus infection. So COVID-19 symptoms include fever, chills, cough, shortness of breath or difficulty breathing, fatigue, muscle, body aches, headache. Very unique for this is the new loss of taste or smell, sore throat, congestion, runny nose, nausea or vomiting, and diarrhea. So you'll kind of notice when thinking about wildland firefighters and their exposure to dust, to smoke, many of these symptoms may overlap with those. So really trying to think about what is outside of your normal range for what you feel on a fire, what you feel on day 10, day 14, after many days of 16 hours. So estimated incubation period for COVID-19 is 2 to 14 days, and recommendation of seeking medical care immediately if you have trouble breathing, persistent pain or pressure in the chest, new confusion, inability to wake or stay awake, and bluish lips or face. So complications include pneumonia, respiratory failure, multi-system organ failure, and there's really a wide range of illness severity. So, like I said, not showing symptoms at all, so being an asymptomatic individual going from mild to severe illness, but can result in death. So then just giving an overview of our wildland firefighter specific guidance that we've created with our interagency partners. Really, we're focusing on prevention. And one of the first kind of concepts that came out for the wildland fire community is this module is one concept. So isolating or insulating as a unit. So really trying to create that family unit, that close environment, so that you're having less exposure to your crew, your module, your family from the outside. So it's important that everyone make that effort, not only on the job, but also off the job as well, to isolate and insulate their unit. So when possible, crews should not interchange personnel or equipment between units, and really limiting the number of personnel who must interact with people outside of your unit. So when fueling vehicles, when picking up supplies, when going to fire briefings. Also really prioritizing reducing fatigue and maintaining healthy throughout the season. So getting that proper rest, hydration, and nutrition should be prioritized every day. So isolation of your unit will require initial planning. I know right now everyone is being recommended that they come to a fire assignment with 3 days and be self-sustaining as a module. So coming with ready to eat meals, coming with all of the necessary supplies that they'll need. So, and implementing ways to isolate from other crews. So using only 1 or 2 individuals from your crew to go into camp to get supplies, designating maybe crew overhead that go to briefing instead of having, multiple people from your unit, utilizing virtual tools as well. So remote briefings could be a way, radio briefings as well, to really not bring as many people together as we're used to this fire season. And I understand that's difficult. Everyone, sees a map on a tailgate and instantly wants to crowd, but it's being cognizant of trying to really create that module as one and insulating. So, and then going into that, if close contact with others outside of your module, your unit is necessary, it's advised that all personnel wear cloth face coverings and masks as a source control, and really being cognizant of that 6-foot social distancing and maintaining that throughout the workday. We're kind of lucky in this profession in that we work outside. So having the opportunity to have that 6 feet is a bit easier in this workforce. So then preventing spread around your crewmates and your coworkers. And one of this is through cleaning and disinfecting frequently touched surfaces on a routine basis, your tools that you use every day, the vehicles that are used every day, and really following the products that are approved by EPA for use. So diluted household bleach solutions and alcohol solutions that contain at least 70% rubbing alcohol. And then maintaining a really high level of personal hygiene. I know that can sometimes be difficult on fire assignments. I will admit, I've been one to not shower for 14 days, but really being cognizant this season, washing your hands with soap and water, using a sanitizer with at least 60% alcohol, especially after blowing your nose, using the restroom, before putting anything in your mouth, preparing food, and after touching those high contact surfaces, especially in communal areas. So fire camps, as we all know, can include thousands of personnel living together, working together, often in remote locations, and often ways they're little communities that just pop up all over the Western US throughout fire season. So additionally, these fire camps have many people coming and going throughout the day. So really trying to reduce the number of people, maintaining your spacing, and using masks when that isn't not possible. So additionally, fire camps can include, because they're not possibly doing arduous conditions, but individuals who may be at a higher risk for COVID-19, for severe illness. So the next presentation will go into more screening procedures as well, but really recommending as can screening for temperature and symptoms for everyone entering fire camp, doing daily screenings, providing everyone individual hand sanitizers, ensuring that those high-touch surfaces on bathrooms, hand wash stations are stocked with hygiene products and cleaned regularly. I went to a fire out in Arizona early on in the season, and one thing I saw for kind of limiting that high-touch surface contact was the staffing of drink stations and limiting the number of people who were touching and going up to the food unit, having everyone maintain spacing, no one touching the handrail, and instructing people not to share any kind of personal items. So, and often fire camps can be at schools or be in yurts or set up trailers. So where you can, increasing the ventilation for those inside areas. So having fans and open windows to create outdoor air circulation. So, and then disinfecting using those EPA approved cleaners, cleaning showers, those commonly touched surfaces, making sure that the individuals doing any cleaning are trained on the proper application of the disinfectants and have proper personal protective equipment or PPE as well. So also instructing everyone to avoid placing toothbrushes or anything that goes into your mouth on those potentially contaminated surfaces as well. So additionally, creating kind of housing areas where crews module as one, can isolate and insulate themselves from other crews. I know there's been a heavy use on spike camps this season as well to really reduce the amount of people in those larger fire camps. So really creating space for everyone on the fire line. So also ensuring that medical staff and fire are familiar with CDC guidance for healthcare professionals, which include additional infection control measures and PPE that should be worn when caring for individuals with known or suspected COVID-19. Additionally, this season, we've seen there is concern for wildland firefighters coming back home. This profession includes a lot of people who are moving in and out of areas, traveling all over within 14 days. So really being cognizant of how they feel. So firefighters should continue to self-monitor for fever and symptoms and follow guidelines for if individuals are feeling sick. Personnel who have vulnerable family members within their home should consider social distancing from those members or wearing a mask when distancing is not possible, and really trying to quarantine for 14 days post-assignment if there is a concern. And lastly, I just wanted to touch on what about that possible risk between co-exposure for wildfire smoke and COVID-19. So wildland fire smoke is a complex mixture of air pollutants that are harmful to human health. The relationship between smoke and COVID-19 has not yet been studied, but looking at past epidemiology studies of respiratory infections and wildfire smoke, mostly in the community setting during a large fire event, there have been an increased risk for hospitalization, for emergency department visits, for respiratory infections, including pneumonia and bronchitis. So the smoke could increase the risk and severity of respiratory infections that we see for COVID-19. So exposure to air pollutants can cause irritation in the lung, can cause inflammation, can alter the immune system, which can lead to an increased susceptibility for respiratory infections. So in addition to making you more susceptible to infection as well, there may be a risk for developing more severe disease outcomes. So the same inflammation markers that we've measured in wildland firefighters performing work and being exposed to smoke are the same inflammatory markers that are on the pathway for severe disease outcomes, such as cytokine storming for COVID-19 infections. So it's hard because some of the symptoms of COVID-19, and like I said before, do overlap with that smoke exposure. So it can include cough and sore throat and shortness of breath and difficulty breathing. If you've had enough exposure, you're getting nausea and disorientation as well from that carbon monoxide exposure. So really trying to reduce risk where possible. So considering tactics that can safely reduce exposure for both COVID-19 and for smoke while meeting operational objectives. So in past exposure assessment studies for wildland firefighters, we see that tasks, not a surprise to many, but holding, firing operations, and mop up are where firefighters can have elevated exposure to smoke. So really trying to be cognizant of when you're doing those and when tactics can be adjusted to meet operational objectives, but reduce exposure for individuals. I know for myself, last summer, one of the things we did is for holding, we were standing there, couldn't see in front of ourselves, but my squad leader made the decision to, instead of just having us stand on the line in one general place, to have us patrol every half hour instead, to look for those spot fires. So we weren't reducing exposure entirely, but reducing our overall cumulative exposure over the shift was definitely happening. So COVID-19 is an additional risk to consider when assessing all risks in the wildfire environment. So we can't completely eliminate it, but we should be trying to eliminate exposures where we can and reduce overall risk. So provided are some links to get more information. A lot of what we've developed is adapting other guidance from business and employers, the business FAQs, and also OSHA guidelines for preparing the workforces for COVID-19. That's all I got, and I will take questions when everyone else is done.
Great, thank you so much, Dr. Navarro. And maybe during the next presentation, you could paste some of those links right into the chat box, because then people can click on them kind of while this is going on. Similarly, attendees, participants, feel free to type questions for Dr. Navarro or any of our presenters in the chat window. Most of them we'll just hold till the end. I want to make sure we get through all our presenters and share that information, but we should have time for questions and answers at the end as well. So next up, taking a slightly different angle, Dr. John Piacentino will talk a little bit about testing. And John, you can go ahead and you should be able to, I guess I should stop sharing. You should be able to share your screen, and I will take the opportunity to introduce Dr. Piacentino. I'm really pleased to have him on the line today. He is the Associate Director for Science for the National Institute for Occupational Safety and Health, NIOSH, at the Center for Disease Control and Prevention. His current focus is on advancing science excellence by promoting the establishment of strong scientific evidence as the basis for planning, development, and disseminating NIOSH science, as well as the guidance and recommendations. So it's nice that that's also sort of the mission of the various knowledge exchanges, really basing our decisions in science. So that's, although he comes from a different field, it really resonates with me. Prior to NIOSH, Dr. Piacentino worked for the Department of Labor in the Occupational Safety and Health Administration. And he received his Doctor of Medicine from Temple University in Philadelphia. And he also worked on the internal medicine residency at Temple. But he's completed, in addition, completed a Master's of Public Health at Johns Hopkins Bloomberg School of Public Health. So he brings a lot of expertise and science to the table. And John, I think when you're ready, we're all set to go. Let's see, let me, okay.
Okay, great. Can you hear me okay?
Yep, you're sounding good. Thank you.
Yeah, and for whatever reason, it seems like I may have dropped out of presentation mode, so.
No, we can see the first slide nicely as the way it should be. So
yeah, very good. Okay, so yeah, thank you very much. And similar to Dr. Navarro, I'll state that again, this information is clearly not going to be exhaustive. We do our best to make sure that we provide the most up-to-date information possible, but please recognize that information related to SARS-CoV-2 and COVID-19 is rapidly changing. So I would also encourage you to go to the CDC website for the most up-to-date information. Let me just take a step back. I should say, you know, I know that we had me slated to discuss testing. I'm bracketing the talk in terms of testing with also screening and contact tracing. And the reason why is that screening, testing, and contact tracing are three tools that folks can use to really try to reduce the spread of SARS-CoV-2 in workplaces and in wildland firefighting. And so if I may, I'm going to cover all three tools together because it's a nice little suite. As Dr. Navarro noted, CDC has guidance for businesses, and I'm just showing a picture of the business landing page with the web address at the bottom. Again, I encourage folks to visit that web page. So let's talk a little bit about screening. And so screening is very interesting because screening is an opportunity to identify individuals who may not even know that they could be infected with SARS-CoV-2. And so screening for employees for things like fever or perhaps other symptoms is certainly an optional strategy. Just a little note that prior to implementing screening, it's recommended that you ensure that their sick leave policies are in place and flexible, consistent with public health guidance. And employees should be aware of what these policies are if there are any. And so it's important that before you initiate screening that you have this addressed. Unfortunately, screening may not be completely effective. And the reason why is because people without symptoms, these are people who are there, sometimes you'll see that word asymptomatic, or individuals with mild or non-specific symptoms might not be identified through screening. So that they may not know, or the screening method may not pick them up. And screening certainly is not a replacement for other protective measures. And so this point, I'll go beyond this and say beyond it's not a replacement. I often think about the protective measures related to SARS-CoV-2, like preventing SARS-CoV-2 infection in workplaces, as being a bit of a Swiss cheese approach. And that is that there are multiple recommendations that get layered in, and hopefully you layer in enough recommendations that you cover up all of the holes. And so screening is just one of those strategies that you can put in place. And it's not intended to displace or be the only strategy. So I would say, consider encouraging individuals planning to enter the workplace, or in this case, wildland fire camps. You could think about self-screening, and self-screening is you yourself try to figure out whether you may be infected with SARS-CoV-2. And so you could do things like take your temperature. You could respond to questions. So for example, are you under evaluation for COVID-19? Have you been diagnosed with COVID-19 and not yet cleared to discontinue isolation? Or do you live in a household with someone who's presumed or diagnosed with COVID-19? These are all examples of screening questions. If you are going to do in-person screening, and that means people will arrive on site and then you'll be administering, say, a questionnaire and perhaps taking a temperature, it's important to make sure that you conduct them safely and respectfully. So that would include things like trying to maintain physical distancing and following physical distancing guidelines, or also being mindful of confidentiality of medical records. And it's important to try to make screening as private as possible, and make sure that the screening, that you do not make determinations based on race or country of origin, and be sure to maintain confidentiality of anybody's medical status and history that you may collect. So another word about, we'll say that the in-person screening, and that is a thought about protecting the screeners, right? And so there are several methods that employers can use to protect any employee that may be conducting temperature screening or screening on behalf of the organization. And so again, reflecting on social distancing, trying to maintain a distance of greater than 6 feet from others. You could ask employees to maybe take their own temperature before coming to the workplace. You could use physical barriers to eliminate or minimize screening or exposures. And also think about personal protective equipment. So if social distancing or barrier controls cannot be implemented during screening, there's certainly a role for personal protective equipment. And that would be for use when the screener must be within 6 feet of an employee during screening. All right, so let's talk a little bit about testing for COVID-19. And so screening oftentimes can be a gateway for testing. And so when we talk about testing, there are really two types of testing that we could be talking about. And one type of test is called viral testing, and the other type of testing is antibody testing. Viral testing tells you if you have a current infection, right? So viral testing is actually testing for the presence of the virus. In antibody testing, where you're testing for the presence of antibodies, and that would be the body's immune response to infection with SARS-CoV-2, the value of that testing is really it's telling you about previous infection. And so the recommendation here is that antibody testing should not be used to make decisions about returning persons to the workplace. CDC certainly has guidance for who should be tested, and so we're going to talk a little bit about that guidance in a moment. I do want to make a point in one of our guidance documents, and that would be the testing in non-healthcare workplaces. There are these features in this document that really talking about making sure that employees and workers have the right information when engaging in testing, right? And so this is the idea of informativeness and consent. And so it's important to make sure that employees undergoing testing receive clear information on the manufacturer and the name of the test, the type of test, what type of test will you be doing? What's the purpose of the test? Information related to the reliability of the test, maybe any limitations associated with the test, who's going to pay for the test and how the test will be performed. And so the second bullet really gets to, once all of that's out of the way, if you will, then, once you get the results, what does that mean? How to understand what the results mean. What are the actions associated with the results? And that would be both for negative and positive results. Who's going to receive the results? How the results may be used, and any consequences for declining to be tested. And so can you decline testing, and what would be the consequences associated with that? I'll also note that individuals tested are required to receive patient fact sheets as part of the test's emergency use authorization. And more specifically there, the FDA provides emergency use authorizations for tests. And when I'm talking about tests here, I'm actually referring to the viral testing. And so individuals tested are required to receive patient fact sheets. And these are readily available on the FDA website. So you could go to any, if you knew the name and manufacturer of a test, if you will, you could go and find that information. It's really easy to find. All right, let's talk about who's getting tested. And so, and here again, we're talking about viral testing. This is the testing where you're testing for the presence of the virus, also a current infection. And so one group of individuals to get tested would be those with signs or symptoms consistent with COVID-19. And so another way to think about this is diagnostic testing. I think this person may have COVID-19. To help figure this out, I think it would be important to do a test. And so that's considered diagnostic testing. Another group of individuals would be folks that don't have signs or symptoms, but they were exposed. Okay, so I think I have a known or suspected exposure, in which case I'm going to test that person. And there the interest is, of course, in detecting an early infection that may have resulted because of the exposure. The third group would be folks that don't have any signs or symptoms and they haven't been exposed. And generally this approach is taken, you'll see the blue text there, it says in special settings. And so some settings have been really important to figure out, I want to make sure that COVID-19 is not in this particular work setting. And so a nursing home would be a great example of that. Nursing homes, of course, where you have healthcare workers, you have populations which are particularly vulnerable to infection. And so you want to make sure that infection isn't present in that particular workplace. High density critical infrastructure and other critical infrastructure settings are also good examples. Again, you're concerned about the transmissibility of the infection within that particular environment. I want to talk a little bit about testing to determine resolution of infection, and that's in unique settings. We'll touch on that in the next slide. And then the last group would be public health surveillance, and this is slightly different. So in the first four, we're talking about testing of individuals. Public health surveillance is really thinking about taking all of these individual test results, pulling them together, aggregating them and grouping them. And here you're trying to figure out what is the burden or the prevalence of SARS-CoV-2 within populations. And so that stands apart and is somewhat separate than the other four bullets. Okay. So I promised you I would talk about testing for determination of resolution of infection. And I want to highlight a difference that has come up, and I think in the past month or so. And that is that most people do not require testing to decide when they can be around others. And I'll put it more plainly. If you were to get SARS-CoV-2 infection and say had a test that showed that you had the infection, it's determined you have COVID-19, and then the next result would be, of course, you would be isolated. Then the question is, do you need to use testing to determine whether or not that infection resolved? And here's the change. And the change is that no, you don't. You can actually say, look, I think you've recovered. And to make that determination, it really would be 10 days since the symptoms first appeared, 24 hours. Now, that's true. So you have to wait this 10 days. then it's in the last 24 hours, and you can't use a medication that reduces fever. You would have to be fever free, right? So you'd have to be able to demonstrate that somebody doesn't have fever within this last 24 hours. And you'd also want to make sure that their symptoms are improving, okay? Now, there of course are exceptions to every rule, if you will, or for every approach, and that is that there are some individuals who are severely immunocompromised. And in those cases, you may actually need to use testing to determine whether or not they have resolved infection and whether or not they could be around others. Okay, let's talk about testing people without symptoms, right? So the first grouping was really talking about, I think you might have symptoms, and so I want to test you. Let's talk about this grouping of folks who don't actually have symptoms. Now, as Dr. Navarro has already stated, SARS-CoV-2 is very contagious, and this is due to the fact that there's a high level of shedding in the upper respiratory tract, and this happens through coughs and sneezes. Some folks, you might hear this terminology about pre-symptomatic individuals. These are individuals who ultimately will go on to develop symptoms, and they're infectious, if you will, 1 to 3 days before the onset of symptoms. And it's thought that, maybe up to 40 to 50% of cases may actually be attributable to transmission from folks who don't have any symptoms or folks who didn't have symptoms but ultimately developed symptoms. That's that pre-symptomatic group. And unfortunately, asymptomatic transmission really is the Achilles heel, if you will, of COVID-19 control. It makes it rather tricky. And various population surveys indicate a wide range of people without symptoms who ultimately go on to have a positive test. Some considerations for testing people without symptoms, and that is the testing should not supersede existing infection prevention and control interventions. This gets back to my previous statement about screening, right? And so we're trying to layer the cheese, if you will, to cover up all the holes. So testing is a part of it, but it doesn't supersede existing infection prevention and control interventions. And really, testing should be used when results will lead to a specific action. Unfortunately, the longer the turnaround time, the more opportunity for ongoing transmission while you're waiting for results. Testing individuals with exposure. Okay, workplaces for which these approaches may be considered include workplaces where physical distancing is difficult and workers are in close proximity to one another, right? Workplaces in remote settings where medical evaluation or treatment may be delayed. I think about this particularly with this group. Workplaces where continuity of operations is a high priority. So, and this would be for critical infrastructure sectors, and workplaces providing congregate housing for employees. And please note in the parenthesis, wildland firefighter camps. And so testing asymptomatic individuals without exposure. Testing asymptomatic individuals with exposure, and I'm going to land on this because this is going to be a segue to contact tracing. And so sometimes there are folks who have been exposed, but they don't have symptoms. Testing is also recommended in this situation as well. So it's recommended for all close contacts of persons with SARS-CoV-2 infection, especially initial testing during an outbreak of pandemic due to the high likelihood of exposure. In some settings, you could consider broader testing, and that would be beyond close contacts. This could be especially important if you're worried about really trying to control transmission and there could be a high-risk setting. And this setting would refer to places like, say, meat processing plants where you have a lot of density within that particular setting. Nursing homes, as we pointed out previously, and that's due to not only the density, but also the vulnerability of that particular population. Let's briefly talk about management of symptomatic workers. And I'll just mention this because it's procedural, and I think it's helpful to sort of recognize or understand that procedure. Workers whose entry screen indicates the need for further evaluation. Notice how that slide says further evaluation and not testing. And the reason why is because, okay, you could answer yes to some of your entry screening. The question is what happens next? And what happens next is this idea of further evaluation. One is if you're suspicious for COVID-19, certainly they should be sent home. You encourage symptomatic workers to self-isolate and contact a healthcare provider. And the reason to do that is because that's how you make a determination as to whether or not somebody, one, may have COVID, and two, may need testing. Provide information on the facility's return to work policies. If you're going to send somebody home, they should have a clear understanding of when can they come back. You may have to, now in this setting, this may be a little bit difficult, but to the extent that you can inform human resources and worker supervisors, And perhaps there's an intersection there with an incident command system, and also disinfect workstations or tools and equipment that have been used by the symptomatic worker. Additional response to a confirmed case. Now, what if you have a confirmed case of COVID-19? This is interesting because now you're starting to trigger this idea of contact tracing. Now, when you do this, and so you want to alert workers that they may have had contact with somebody with COVID-19, you have to be careful, right? You want to maintain the confidentiality that's required by Americans with Disability Act. You can provide guidance to fellow workers on how to proceed based on CDC public health recommendations. On-site healthcare personnel should follow appropriate CDC and OSHA guidance for healthcare. And this last bullet is about working with state, local, tribal, and territorial health officials, and we'll get into that more in a moment. Let's talk a little bit about case investigation and contact tracing. Case investigation really is the identification and investigation of individuals with confirmed and probable diagnosis of COVID-19. And so this is, you're going to investigate that particular case, right? That's case investigation. You want to know things about who is this person, where did they work? And that's the case investigation part. The next part is contact tracing. Contact tracing follows case investigation, and that's the process to identify, monitor, and support individuals who may have been exposed to the person with COVID, right? So after you've done your case investigation, now you've moved into contact tracing. Now, health departments really have a prominent role in this particular activity. They actually lead case investigations. When health department personnel investigate cases, they'll ask people questions, as I stated, about their work status, environment, etc. However, given the large number of COVID-19 cases, it's possible that a health department may have difficulty doing this, right? They could be overwhelmed, they might lack the resources. And so in this case, employers can really assist in helping with conducting some portion of this investigation. Now think about this though. You're thinking about who this case may have come in contact with, right? And so employers, I think, can really get into the business of workplace contacts, but there may also be non-workplace contacts. And so you want to keep a little bit of a difference there in case of what questions you would recommend an employer to ask versus not ask. The level of interaction between health departments and employers varies depending on a variety of factors. But just to play this out, when a COVID case is identified, a health department may proceed in a number of ways. So perhaps the health department will actually ask the employer for help in understanding the risk of transmission, and that will be it. Other times they may rely on the employer to identify workplace contacts, or they may conduct workplace contact tracing without directly engaging the employer. Now, I mention this because I think about this particular workforce as being mobile. There's a mobile component here. These are folks who are coming together on a temporary basis, leaving that particular site and then going somewhere else. And so for me, I think through what would it be like to try to conduct case investigation and contact tracing with the mobile workforce. And I think that communication and record keeping could in fact be key here so that you have a way of tracking people through a particular system so that you can at least notify folks if there has been an exposure. And this is a nice segue to what can employers do to take the following action steps to prepare for one of these investigations. And so you could think about, maybe I need to have a COVID-19 coordinator or a team. So if I get the call that, oh my gosh, there was a case, you have somebody to refer this person to. You can create and implement a preparedness, response, and control plan. You could collect information about your workplace. And this is the idea of making sure you know who's on site and for how long, duration, etc. You may have to try to support individuals through the hazard evaluation and prevention activities. Again, whether or not there are leave policies, and review that. And ultimately, of course, maintain communication with employees. I mentioned the development of an infection control assessment and response plan, and I think Dr. Navarro did as well. I just want to make sure people are aware of this particular resource that's available on the website, and this really guides you through development of one of these plans. And so in summary, I'm just going to end up with this idea of collaboration, and it really is essential to interrupt the spread of COVID. Collaboration here is key. I can imagine that for the purposes of diagnostic testing, people will need to collaborate. Perhaps it's between a personal physician, an employer, their colleagues, etc. I'm thinking about the importance of communication and collaboration during case investigation and contact tracing. And so it's important to sort of work through a collaborative atmosphere, but also be respectful of things like privacy and confidentiality laws. Similar to Dr. Navarro, I also have a final slide here with some information that I think might be helpful to individuals if you're interested in reading up further. And with that, I think I'm going to be finished. So thank you very much for the opportunity to present here.
Thank you. That was great. Really good overview of all these different facets. You had some information on, I think, your third to last slide, not the summary slide, but right before that, that at least on my screen flashed by a little too fast. So if you don't mind either bringing that slide back up for a second, or maybe it could be just as easy to post the information in the chat window from that slide. Maybe building on that, we will be sharing all the presentations and the recording. So if there are pieces of this puzzle that you missed as a participant, we'll make sure to get that information. There are a lot of good links here, and it can be a little hard to keep track of them all, so I appreciate that. So we're going to change gears a little bit, and we're going to turn to some lessons learned that have been compiled by the Wildfire Lessons Learned Center, and then the sort of on-the-ground experience from some fires in the Southwest with Jason Coyle. And it looks like Alex is already getting his presentation together. He's a step ahead. That's great. I appreciate that, Alex. But I do I can't let him get started quite yet because I do want to go ahead and introduce him. So Alex Victora has been a staff member at the Wildland Fire Lessons Learned Center since 2013. And he's been assistant center director since 2016. We're really glad to have him in that position. He's a great guy to work with. He began work in wildland fire in 1999 as a fire effects crew member at Zion National Park. And he spent a decade as part of the Zion Fire Use Module based in Zion National Park. But he also brings to the table a undergraduate degree in biology from Lewis and Clark College in Portland, Oregon. And so without further ado, Alex, I think I'll turn it over to you. And well, maybe I should add one other thing, and that is that please continue to add questions or comments in the chat window, and we'll try to address those at the end during the Q&A. And with that, Alex, you can take it away.
Okay, thanks, Xander. Can you hear me okay?
Yep, it's sounding good. Thank you.
Okay, very good. Well, before I get on to my slides, hello from Tucson, Arizona. I'm one of the Lessons Learned Center staff members that's based here in perpetually sunny, warm Tucson, Arizona. Hello, and thanks so much. Just can't underscore this enough to Xander and particularly Kat and Dr. Navarro, excuse me, and Corey Butler from CDC NIOSH, as well as Dr. Piacentino today. Thanks a ton for Jason Coyle getting on, and then to the participants. Scrolling through the participant list, I recognize a bunch of names, but I don't recognize even more names, and that's super important. So thanks to you all, and thanks really to Xander and Dr. Navarro for coordinating and putting this together. My slides are going to really focus on just one link and one place on the internet where we do our business, a lot of our business, not all of it, but a bunch of our business that we do at the Lessons Learned Center, and that's wildfirelessons.net. That is our main platform hub for all the different places we do what we do, gathering, sharing, monitoring stuff in the business of wildland fire and inside of cyberspace there. And on the homepage, that you can see, we've got a lot of coronavirus on the homepage. We think the homepage has strong immunity to the virus, so we're good. One of the most basic things right on the homepage is a link to all the COVID-19, coronavirus, SARS-CoV-2, all the words we use to describe the pandemic, right? All the reports we've seen thus far this season, this year, 40 of them as of this morning, more in the wings today, in fact. All those reports are there, and with a single click there from the homepage, you can have a look-see and scroll to your heart's desire. You'll see different types of COVID lessons, and we encourage folks to have a look at that and try to make relevant what's relevant for them there. Also, to give you a hand, we have tried, and we will do so again shortly, we've tried to summarize the first kind of batch of lessons that came to us primarily in the form of what we call rapid lesson sharing reports. And this is a report that takes a look at the stuff that we saw between March and June. It's 10 pages. The entire Lessons Learned Center staff had a hand in trying to kind of distill down all the information that we saw in all those reports. It's quite a heavy pull. Travis Dotson, our center analyst, and Paul Keller do remarkable work continuously, and this is just but one example of that kind of distillation. And the second version of this summary, there may be many of these type summaries, but the second version is underway, and I'll give you a little sneak peek at some of those lessons momentarily. Also on the homepage is a way to take a look at what we call connected communities, and we have one connected community in particular that's dedicated to COVID-19 and fire season 2020. As of yesterday morning, we had 472 members in that community. We provide linkage back, of course, always to the CDC in deference to their expertise and authority. And to join this community or other communities at wildfirelessons.net, all you need is to sign in if you have an account up here back at the homepage, upper right-hand corner. Sign in if you've got an account. If you don't have an account, you can also sign in, click sign in, and build an account. It's a quick process to set one up. Basic tool that we use to keep people in the loop is an email service. We scrutinize every single email we send out. Believe it or not, we send out a lot of email. I feel like we've sent out a ton of email in the midst of the pandemic. If you're not subscribed, the best way to sort of keep your finger on the pulse of what we're up to and what we're seeing is through this service. We don't do anything with your email. We don't ever share it or sell it with anybody. That's a simple process, basic tool I want to make sure folks are aware of. Another really basic tool that's been super important in the midst of the pandemic is what we call the rapid lesson sharing process and tool. We've revised how we gather, based on what we've seen in the midst of the pandemic. We revise how we capture that stuff. There's a form you can click to here. If you click this button, it'll take you to a quick spreadsheet that'll guide you through what it is we think a good rapid lesson sharing document should look like. If you've got something already, and a lot of what we've seen in the midst of the pandemic has come or started off as an email to a unit, to a national forest, for example, or to an entire region. And we've got a lot of folks who are thoughtful to pass that stuff on to us. We always go back to the sort of the initial author to make sure they're good, sharing it out broadly to the entire globe functionally. And so yeah, if you've got something built, just send it to us, and we will work with whomever the sort of initiating author is or authors to make sure it's all good and reads well. When you click submit here on the page, then nothing instantaneous happens on the internet. We always again work with authors to make sure they're good to go with what's what. Okay, so I mentioned this first version of analysis and summary, 23 RLS report summarized in 10 pages. Version 2 of this work is underway, and we hope to see that in the next couple weeks. And I chatted with Travis Dotson, our center analyst. He is based in Coopeville, Washington. Chatted with him yesterday. He was sitting in line waiting to get the ferry from Coopeville over to Port Townsend, and he was making that journey to give the folks over at Olympic National Park a hand. They've had a bit of a mini fire bust here, and Travis is headed over to give the Olympic folks a hand, and I caught up with him. He would be on the webinar if he wasn't assigned here listening in, but he shared with me a couple of the big things that he thinks he's seeing in the next version of this analysis. And one of the basic ones is not so much a lesson, but a noteworthy observation. I would say that the tone and the focus of what we're seeing from folks is starting to shift from focus on prevention to one of response and containment. And to me, when I see this graphic, this slide, I think, you know, a little bit about what the average sort of fire season, kind of the arc of an average fire season, lots of focus on prevention early and then a shift to response and containment. Never looking past the prevention tools, of course, and RLSs and the work that we do. We will continue to sort of reemphasize the preventive measures associated with containing or preventing the spread of the virus. Another big theme that's starting to emerge for Travis is the importance of local knowledge, and this is a thing that wildland firefighters learn early, is that when you travel to remote exotic locales, Alaska or Florida, I'm not sure which is more exotic, honestly, but the power of local knowledge is critical in that collaboration that Dr. Piacentino, emphasized just moments ago. This is central to, I would say, the operational business of wildland fire, and in the midst of the pandemic, it's super critical, and the local knowledge and expertise and actually authority, comes to us in the form of frequently county health authorities or other local health authorities, and establishing well, one of the big lessons Travis pointed out is that, and this has been alluded to here, is that county authorities, their capacity, their resources vary widely. This is a picture from an RLS from earlier in the season where every firefighter assigned to a particular fire in the state of Florida was tested prior to demob. That was sort of, early in the pandemic where we were, as we continue to be, but at this point in time, we were still really learning a lot, and the pace of change was really aggressive. I don't suspect that there are any fires out there that are testing all firefighters prior to demob. I think we've learned a lot and maybe understand now a little bit more about the importance or where the emphasis should be with our testing for lots of reasons. But the point here is that response and capacity varies widely, which perhaps isn't super surprising. And again, to underscore this point about collaboration, which was just mentioned moments ago, one of the lessons Travis has seen a few different times here is that this notion of getting to know your county health authorities, if there's an incident in a given county, and we've seen lots of evidence of this from folks like Jason Coyle, for example, that there's lots of good work that's been done and will continue to be done with IMTs, incident management teams, making those connections early with county health authorities. I think any county out there would be curious to know if they're bringing in 1,000 or 2,000 or 3,000 folks from, all over the country, essentially. And so they may reach out to you, but if they don't, for sure, get to know those folks early, reach out to them. That collaboration is super critical, super important, should happen early. And I'll wrap up my quick remarks here, perhaps to yield back a bit of time to Jason with a simple button back on our homepage here, which is the About Us button. And you click it, it reveals all of the entire staff of the Lessons Learned Center, our smiling faces here for you, as well as our contact info. And that's the point here. If you've got a question, if you've got some lessons to share, you need a hand with something, we may not know the answer, but we'd like to think we can put you in with who does. So with that, again, wildfirelessons.net is where you can find all our resources and links to all the other places we do business on the internet. And that wraps it up for me to give perhaps a little bit more time to Mr. Coyle. So I will stop my screen share. Thanks, Xander.
Thank you so much, Alex. And that's a great overview of a lot of good resources. And along those lines, I'm going to just take a little minute in between this transition and share a couple of resources from some researchers. And we were going to try to include another presenter, Matt Thompson, today, but we couldn't. And so on screen, there's a new COVID-19 fire incident specific risk assessment tool. And I'll post URLs for all of these when I finish talking. But So that tool is available. It's from some Forest Service research, a paper, a peer-reviewed journal paper connected to that research, the potential of COVID-19 outbreak and fire camp, modeling scenarios and interventions is also available. And then another paper that was just shared with me this morning from a colleague in Arizona, more on the social science side, looking at a rapid preliminary survey from Arizona wildland urban interface residents on their expectations and experience with the 2020 fire season. So there is a lot of learning going on out there, and it's probably difficult for all of us to keep up, but that's sort of the point of sharing some of these resources. So with that, we'll change gears, and Jason, if you want to start sharing your screen, please do so. And while Jason is doing that, I'll take the time to introduce him. I was really pleased through this webinar process to get to meet Jason. He comes well recommended. Everybody seems to like him and really value his opinion. So it's great to have him on today. Jason became a firefighter for the Sedona Fire District back in 1998, and he's now the assistant chief. And in addition to leading this exceptional group of firefighters, he's participated in over 80 large incidents, including wildfires, hurricanes, and even the Challenger shuttle disaster. He's currently an operations section chief. So he brings one of the reasons we wanted to have Jason on today was that on the ground experience and sort of the lessons from the field. He did receive an undergraduate degree in applied management, and as well as a master's in leadership in 2011, both from Grand Canyon University. And he's currently pursuing a PhD in performance psychology. And he's one of the reasons we turned to him. He's really stepped up during the COVID threat. He's been taking classes online at Johns Hopkins and University of Washington, and really beefed up his knowledge. So we're pleased that he's able to share that with us today. And with that, Jason, I'll turn it over to you. Looks like your slide looks great on the screen.
Perfect. Hey, thank you, Xander. And thanks to everybody else that set the stage for a good conversation. So full disclaimer, I'm not an epidemiologist. I did take all the classes that Johns Hopkins had on Coursera and the University of Washington to try to get better at this. But basically my goal is to be able to communicate some of these issues more effectively. So if I can do that, I feel like I'm winning. So anyways, how I got here. Here's how it all began. I was an ops chief. I have a background as Xander said in fire-based EMS. And then I became the medical officer for our team. And that's pretty much how it started. And what I started to figure out, because I was certainly part of this problem, is at the very beginning of this, and going back to the beginning of the year, as we had a lot of conversations among the wildfire folks about what we need to do, is that we have a lot of experts in wildland fire and highly skilled operators in incident command. But public health's not our thing. And but we are used to having to adapt to different situations. We pride ourselves on our ability to do that. So we adapted and started punching out a bunch of documents and figuring out what we were going to do to make things better. Unfortunately, I think we called these things best practices, and maybe we should have called them, hey, this might work, because it's kind of hard to have a best practice if it's your first practice. I guess it is your best practice, right? It's your best and your worst practice. Anyhow, that's how we started. And that's how I started too, was trying to figure out how it was that we could do the things that we needed to do to keep people safe. But, and this is a little bit of my nerdy side coming out here. So we have a tolerance for ambiguity and our ability to act or not act, that we demonstrate on fires, is because we're comfortable with that, right? We go through that iterative decision-making process. We make incremental gains. We allow decision space for the field. We do all that kind of stuff so we can have the highest decision qualities in an environment of uncertainty. But when we apply that to COVID-19 and we attempt to balance action and risk without understanding the problem, we're not so good at that. I don't know who is good at that. And so we need to understand what the problem is. And that was one of the things that I kind of started to work on was figuring out how I could understand the problem. So then I went on a mission, and that was to gain knowledge and experience, talk to people in the field, figure out like, hey, why did this work? Why didn't this work? What are your thoughts? And the work to identify ways to better communicate some of these complex ideas to improve decision quality. Some of it worked and some of it didn't. And a lot of what I tried is based on what I like. If someone says, well, the guidance says this, and I don't know why the guidance says that, and it doesn't make sense to me, I have a hard time with that. I think in the wildland fire community, we've pushed task, purpose, end state. We've talked about a lot of things about doctrine and everything. And so we need to give people the why. And when they asked me the why, at first I couldn't give them. So kept working on trying to do that. And then what I learned or possibly re-remembered about leadership is that the goal is applying influence in an effective manner where you can change behaviors. In this case, I had to keep reminding myself it's the behaviors that have the most positive impact on reducing transmission. And that was my goal. And the reason I say that's really important is there's as we deal with this issue that is novel to us in wildland fire, it feels good to do stuff. And we do this in regular fires too, right? We fly that load of retardant along the ridge and we think, maybe we can check it up, even when we know it's not going to work, because somebody wants to see us doing something. So we put in some super robust decontamination processes, and then didn't want to address everybody wearing masks when they were in the ICP, things like that. So I think it's important that we continue to look at what focuses on having the most positive impact on reducing transmission. So there are 3 things that I felt like we needed to effectively influence. First one was recognizing that you're not just providing information, you're working on changing behaviors. This is going to be a big deal. It was a big deal. It still is a big deal. New fires in new areas, starting all over again. And that needs to be, the challenges comes along with that, I think needs to be recognized. People need the why, I talked about that. And then the last one was salience with the group. I had it pretty easy. I think I have it pretty easy because people already know me within my team. I'm part of the in-group. And that I've worked on a lot of different fires. I do a lot of the strategic planning stuff, so I'm already kind of one of the nerdier ones. And so that's worked out pretty good. I have one of my captains did the same job for another team, and he was new to the team, lacked that, highly competent, but he had a much different time trying to get people to influence behaviors. And I'll talk about a little bit of the reasons why I think that was. All right, so thing 1, changing behaviors. And the consistent messaging from top to top, agency to agency. I would love that. I don't think it's always there. I know it's not, especially when it comes to some of the state agencies. Some of them, it was a matter of pride for them not to practice mitigations because it demonstrated just how, resilient they were, I guess, or how resistant they were to federal overreach. Whatever the reason was, it creates problems because behavioral change, right? This is what we're trying to do. And the first thing is that antecedent. It's like, if you want to change behavior, model it, highlight the successes, put up signs, make it the cool thing to do. Make wearing masks what people do that take care of their brothers and sisters in the fire, and demonstrate that 24/7. As soon as you don't, then people that maybe for whatever reason don't want to do it to begin with, they're not gonna do it. Again, this is life according to Jason, but this is kind of what I found out. The behavior, positive behavior, mask worn, problematic mask not worn, and then the other part that's important for us to remember is that the pivotal behavior in this case maybe doesn't have anything to do with masks. It's because they go to spike camp, and so things change in spike camp. You get off the reservation, you go rogue, whatever, and you kind of need to realize that, hey, maybe things have to be done different at spike camp. So just remembering your environment, and then the consequence, outcome. It's really outcome, but AOB would sound weird, so that's probably why they didn't do it. But positive behavior should have positive consequences, and vice versa, not vice versa. So and this is where another place where I saw us falling down at the beginning when we tried this, is that the negative behaviors wouldn't have negative consequence. And I'm not saying that we need to, run them out with pitchforks. But if you're telling people this is important and you're telling them it needs to be done, and then you're saying, well, we just need to let people come around, do it on their own. That doesn't work. If people see other people not doing it, then now all of a sudden that you've given them permission to not do it. Yeah, it's uncomfortable. I've had lots of those uncomfortable conversations. But if you're gonna make a position, you have to. You can do it as politely as possible, but I think you need to maintain the standard. So, thing 2 is do your homework. I think I'm a good ops chief, and I've been a paramedic for 22 years. I was a tox medic instructor, ACLS instructor. Back in the day, I did it all, but I didn't do public health. And people that clinicians don't. This is stuff about, fortunately my doctorate work gave me some background in the stats, but we need to know what we're not good at. And we also need to know who we should be looking for that expert opinion and who we shouldn't. And to me, the test is if you understand the science behind the policy, then you won't have the policy be driving the science, or having the explanation of the policy driving the science. And, I talked about that untested best practices. Be skeptical and accept skepticism of you, invite it. As a matter of fact, I would put out these things trying to explain these different graphics, trying to explain complex ideas. And I'd be like, hey, I don't like this. I said, I know it needs to change, but I can't really figure out where. That is a perfect precondition to have somebody provide you with input. If you tell them, hey, I just worked 8 hours on this, what do you guys think? They'll be, oh yeah, Jason, it's nice, but maybe it's not. Maybe it doesn't work. And then understand how to deliver the same message in different ways to different audiences. So sometimes you need a nudge. Sometimes you need to be more direct. The message needs to be consistent, but as leaders, we need to make sure that we're kind of catering how that message is delivered to most effectively reach our audience. Remember, the idea is for them to get the message, not for us to feel good about towing the line or taking a hard stance or whatever it is that we feel like checks our ego box. And thing 3, I talked about credibility in the group. We're all more alike than we are different. And I think if you focus on these things, being trustworthy, active in pursuit of the team's goals, friendly, reliable, and don't make it a red-green or red-blue, red-green's a cartoon, red-blue issue. And then, pull the strings. There's a lot of times good buddies of mine, elk hunting buddies, that I knew were not at all aligned with this mask stuff. And I knew that I felt like, I shouldn't say I know, but I felt like I'd given them all the information they needed to make a good decision. And now they're just being stubborn knuckleheads. Well, me going up and telling them they're being stubborn knuckleheads isn't going to make it better. So, find those proxies to get your message out and give people space to back away from their position. If there are masks or a government plot to, I don't know, whatever, then that's not the idea. The idea is the idea is not to argue with them about masks and its government plot, but the idea is to get them to wear their masks. And, one of the examples I give out is, and this came up, people come to me about masks are not 100% effective. I said, absolutely not. Matter of fact, until the Duke study came out, there was nothing really kind of specific to the cloth face coverings that we're wearing. But a lot of things aren't. Wearing your chaps is still not going to prevent you from getting cut by a chainsaw on your leg, maybe. Seat belts, your fire shelter dang sure isn't going to prevent you from dying in every sort of burn over. And then, that what I would end with in those situations was to contrast the benefit with the consequence. And yeah, that whole can't hurt, might help kind of thing. And then again, how it was applied, set the stage for future change, explain ambiguity, own what you don't know, and say, yeah, this is weird. And, this is, I don't understand this. Put people on notice that the information is going to change, because it is. We're getting better at this. That actually, I think, was from the book Contagion. If you've seen one pandemic, you've seen one pandemic. When you get people say, oh, this is just like so-and-so, maybe not. Engage in conversations on the issues, explain the science, accept frustration and fear. It's real, right? People, and you don't even know why it's real. It could be because their wife's a teacher and she's got to go back to school around a bunch of snot-nosed kids. I don't have any kids, so I can say that. And she's afraid about them getting sick. And that could be driving it. So he doesn't want to believe that it's a bad thing because he doesn't want to believe that his wife can get sick. You don't know all that, except you don't know all that. Working through issues of leadership and helping them understand, improve decision quality of the future. Probably my biggest wins came from walking people down that had planted their flag in one particular camp. Usually, one of them was testing. And we need to test everybody. We leave it. If we're taking care of our people, we're testing everybody before they leave the fire. That's not my view, but that wasn't, telling them that wasn't my view wasn't going to work because a lot of my buddies already tried. And so walking them through and explaining things, asking them questions about what their thoughts were, providing them with more information, letting them arrive on their own, especially when they're people that have a lot of influence, well worth your time. And then ensuring that mitigations remain focused on the areas of where the higher risk exists and adapting it as that becomes clearer. Again, just because you do something to make it feel good doesn't mean it's right. And then some of the things that took more work were changing some of the very long-held politicized beliefs. I mean, I'm still we're looking at different ways to do that. Communicating the testing trade-offs. And I saw, I would love if Dr. Piacentino can explain to me, is it better to have a test with an 80% sensitivity that is effective at a higher percentage of that at somebody that has a CT time less than 30? Or is it better to have a more accurate test later? Those are kind of the things I still don't understand it. And I just tell people I don't understand it, but I tell them some of the things that add to the complexity. Continue to build and maintain your situational understanding, reading peer-reviewed work, making sure that you're staying on top of things, and then maintaining collaboration and dialogue among groups that are done with it. So just, not to write people off, even though it's super tempting when you're busy. And then, I put addressing the memes, and that's the other thing is that it's complex, it's confusing. So what happens is you get these little narratives that say false dichotomies, really what people just say, I thought we said that the fire was more important than Corona, than worrying about coronavirus. But yet Jason talks about wearing his mask first at the briefing. That was like a real one that happened. And, I nicely pointed out, I think it was nicely, that it's not that the fire is more important, it's taking care of our people and providing for their health and welfare. And so we need to do that in the near term by helping them stay focused on the fire and the proximal physical hazards. And we need to take care of that in the longer term by making sure that we send them home to their families healthy. And then, I think some of the stuff that I think makes it harder that I still haven't figured out ways to communicate this. One, the generation time. I feel strongly that on an incident, we could, especially now that we're getting really busy, we could blow it 3 times and have be the generation, the third generation or generation 2 of an event, and then send everybody away. And then we wouldn't realize how bad it was until it was super bad. And then different approaches to planning implementation from region to region. Sorry, but I don't think that you can put a group of people together and give their group a title, and now all of a sudden their decision quality is instantly better when they have no experiential knowledge. They haven't tapped into the people with expertise. And then, part of this, I think it's worth us recognizing, it was already here. It just didn't have the same consequence. I mean, we talk about Dirty August, we talk about Camp Crud. That, we need to get better at infection control anyways. And we need to get better, as like Dr. Navarro said about the smoke stuff. She made me regret 20 years of my decisions. But that needs to happen. And that stuff, we were never good at it. Let's not pretend we were. And failing to focus on the most beneficial actions. I said that 3 times because I think that is the super important thing to worry about. So take homes for me are you educate yourself. Your fire clinical expertise is not directly transferable to public health. Know what you don't know, and then try to figure out enough of it so you can at least have an intelligent conversation with the legitimate experts. And I can tell you that I've dealt with multiple different county health departments. I know there's a lot of them on here. I'd love to hear if they see it different. But, jokingly coming up to them and saying that I got my junior epidemiologist badge after 7 classes from Johns Hopkins and 13 from the University of Washington. But having that conversation and inviting criticism has made for a better relationship. And I think it's helped increase our communication, our effectiveness in the field. And, accept that the emotion is there and it's not just a logical, the way I remember is if you're riding an elephant then you're the logic and the emotion is the elephant. So, kind of approach it from that perspective. And then as we're trying to motivate people to do things, remember that curiosity is linked to motivation. Accept it and make curiosity and make use of the curiosity to reduce those negative states, uncertainty, unhealthy stress response, information gaps. Spend time informing the curious, and you yourself be curious about it. So I think Alex might like this. We'll see. But we talk about being HRO, high reliability organization. And we talk about it all the time. We talk about it like we are it. I'd say we're not. But I thought, hey, let's talk about to close this out, the 5 HRO principles and see what we can do better. Sensitivity operations. I think we need to make sure symptoms and processes are easy to understand and make sense to those at the coalface. I just learned that from a British friend. Since we have an international audience, thought I'd throw it on there. It's like tip of the spear. Reluctance to simplify. Some stuff is complex. And I've made a lot of flow charts and I've tried to make a lot more. Some stuff just can't be reduced to the flow chart. But we have smart people, so explain it to them, and I bet most of them will get it. Being preoccupied with failure. If our mitigations fail, where would they fail, and what have we done to prepare for the failure? How are we going to prevent transmission? And then deference to expertise. You gotta know who the experts are. I talk about being on a fire or on a cardiac arrest on a golf course with a group of doctors, and we're getting ready to go through our ACLS protocols, knocking out of the park. Pit crew design. We have a 21% code save rate with people that are in VFib. That's wonderful. And he comes up to me and goes, "I'm a doctor." And I'm all, "Roger that." I start about to assign him a task. And so, "What kind of doctor are you?" He goes, "I'm a podiatrist." Give him bicarb, which bicarb is something we haven't done for a long time. So, know who the real experts are. And then practice resilience. It's more difficult to communicate and support multiple spike camps, but that's what we need to do. That's what the crews are asking for. And so, recognize that we need to work on building a system that's more resilient to failures. So that way, if that little spike camp up in the woods gets some cases, gets a cluster, then it's not going to affect the whole entire incident. So I really appreciate y'all's time, and that's my spiel. Thank you.
Thank you so much, Jason. I really appreciate you sharing what you've seen just this year and some of the challenges you had. I think that makes it, for me, kind of brings it home. So we have a little bit of time for questions, and I'm thinking that we had great presentations. I don't want to run too much over our 90 minutes. So what we might try to do is take some of the questions and then just provide some links and answers as follow-up after the webinar, because I don't think we're going to get through them all right now. But we'll get started. And let's see, I got to balance all these documents on my screen here. So we'll go back to a question that Megan asked that I thought was really interesting. And it was, looking ahead, do you have any suggestions for how we can set up our resources and programs for next season? What do we need to think about, or what can we do over the winter to improve what we currently have in place? And Dr. Piacentino, maybe if you'd be willing to start a little bit on, yes, we're in the middle of everything, but obviously this is going to go on for a long time. And are there things that we should be thinking about for the future that we might need to do this winter? Or maybe what the resources that to even plan for that activity?
Okay, great. Yeah, thanks for the question. So hard to know the future, but I do have something off the top of my head. I think about how important communication is in this particular setting. I think about, how is it that people come together, leave, come back together, go to other places, and you can transfer important information. And so I would say, and in addition to that, I was really fascinated, I think, with the presentation after me, where there's this lessons learned, and there's real opportunity to look at, what are you learning as you go through the COVID response? I would say that in order to prepare for the future, I think it's worth it to go back through those lessons learned and find out what is it that you're learning now in a preliminary sense, and does any of that actually point toward improvement in terms of either your approach for communication, your structure around communication? Because to me, it seems that managing SARS-CoV-2 infection and managing COVID-19 may hinge on effective transfer of information. I know that's sort of a broad, sort of general way to look at this, but you know, there are other things that seem to me that are out of control, right? What testing technologies are developed, what access do you have to that, and so on and so forth. But I think maybe one thing you might have access to is to think through how you come together through an incident command system and how you communicate to one another. I'm sure other folks have other thoughts around this, so I'll stop there.
Yeah, thank you. Dr. Navarro, do you want to add anything to that?
No, I think that, you know, one thing we're watching and listening is all of those lessons learned that we've been seeing out in the field. I know from my experience, I went out to the Bighorn Fire to kind of watch and see what's working, what's not working. And one of the things that was a really big take pointed to this is that setting clear expectations, setting that clear leader's intent, and what we use in fire is that task, purpose, end state. So really just setting that from the beginning. What are the expectations for prevention protocols in camp, at fires, and at the home unit as well. So, and then reaching out to local public health, I think, is something that can also be happening over the winter to start planning for next fire season as well.
Great, thank you. Let me turn to another question, and I'm sort of choosing these a little bit at random or based on my own preference. Mike asked whether it was necessary to consider second-tier exposure during contact tracing, and what he meant by that was to trace those who are in close contact with a person who was identified in initial contact tracing. So that sort of second ring. And does it even go farther than that second tier? And Dr. Piacentino, that's probably.
I was going to say, can I take? I'll go first. And
okay.
Kat, if you want to add in, or anybody wants to make any corrections, go ahead. So you know, let's start. I want to start all the way back at exposure assessment. And so I think it's important to understand during the case investigation what type of exposure may or may not have happened. And so, you know, when you think about exposure, we think about being exposed to a case. Here you're talking about somebody within 6 feet of another individual, and the time, of course, would be for 15 minutes, right? And so that's how you define whether or not there even was an exposure. Then once you define whether or not there's an exposure, then people start to think about, well, who may have actually fit that definition in terms of exposure. And generally, I see people falling out into 3 groups of certainty. And so the first group is people that we definitely know you had an exposure, right? And these are people that somebody can actually tell you, say, well, I actually shared a space with this person, et cetera. And so there's a certain amount of certainty in that first tier. The second tier are folks that you think you may have come in contact with, but you're not entirely sure. And these might be people who say, well, I was in the same camp during the same time when there was a particular case. I think that case may have actually used some sort of shared facility. And so, yeah, there's a possibility that I was exposed. And then the third tier might generally get to this idea of I can't say whether or not I was exposed, but I can't say that I wasn't. And so then there's that third tier. And then you have to start to make choices. You know, who would you start to consider to be the exposed individuals, with what degree of certainty? And I think then that those choices really hinge on your, I guess, the way you think about risk, how much risk you're trying to control. In addition to that, I think it may actually hinge on your experience. And so if experience tells you that when you initially drew too tight of a circle, you missed cases, then you might naturally progress to start to include people in, say, a tier 2 or tier 3 stature. So that's the way I would start to unravel whether or not you have to go to first, second, or third tier. That's how I think through that. I hope that's helpful.
Yeah, thank you. That's great. Anybody else want to jump in on that, or should we move to another question? Okay, so I want to recognize we're at 90 minutes. I know some people will have to drop off. I think we'll probably try to answer a few more questions and pose on our presenters' goodwill and time just a little bit more. And I think this one might be a good one, Jason, for you to answer first. Did you experience pushback on recording and reporting suspected cases? Or Alex, I don't know if we saw these in any of the rapid response learning. And are there established protocols for Camp Crud or injuries that could be adopted for reporting and tracking suspected/confirmed cases. So, Jason, you want to touch on that at all?
Sure. So I want to make sure I say this right. So it is a reportable injury. I mean, it's a reportable, I forgot what it's called now, but yeah, the county health needs to be involved. You need to make sure that they are reporting that properly. And on what I did was I always would reach out to like it was the forest safety officer, you know, and I actually even asked a question of MFAT, I think before, about the reporting requirements and who was responsible for them, to make sure that I knew who to ask to do the reporting if it wasn't, you know, if it was like not on a forest, but it was a different. And then if the home unit for cooperators like myself, you know, we're responsible for our reporting as far as reportable injuries go. So on that part of it, I think it's key to make sure that you know what that system is. And I did not receive any pushback because it's a requirement to report. So that's, you know, it never really came up. I do know that there's a real potential for there to be disincentives with people coming forward that could impact their ability to self-report, especially if, I mean, face it, right? If you're a contractor and this is the only way you make money and you're counting on a busy fire season, you got a little bit of a cough. Even if you don't purposely do it, you may just say, it's allergies, and then go along your business until later on. That I know exists because we've dealt with that. I don't know if that was helpful or not.
Yeah, thank you. I think it is. Alex, do you have anything to add to that one?
No, I would. Well, yes, I do. And I would echo what Jason just mentioned there. And a thought that is rambling around in my head here, going back to even Megan's question, is there's all sorts of pressures weighing down on the folks, you know, who do the things that we ask them to do in the business of wildland fire. Some of them are, you know, many of them are cultural, and that's a whole layered conversation we don't have time for today. There's lots of cultural pressures, and then there's these pressures Jason just alluded to, and some of the work that focus groups inside the Forest Service, HPIOL focus groups have tried to get at some of those things, and it's real. It is as real as anything. What Jason just mentioned, folks have, for better or worse, as you know, seasonals on crews have a limited window to, you know, basically get as much overtime as they can. We don't have to love that fact, but acknowledging that will absolutely, impact people's willingness and maybe even their ability to raise their hand when the superintendent goes through a screening in the morning after being up all night listening to an entire crew hacking and coughing, right? And that's a real story. That's a firsthand account, not necessarily showing up in RLS documents, but yeah. I do think, though, that once positives happen, I think some of the cultural, you know, the notion of integrity, right? It's one of our core values in our business. And integrity leads people to a place where if they're positive, that's news that's going to get shared more than likely, regardless of what HIPAA might specifically say, if that makes any sense. So, yeah, that's my thought. Thanks, Xander.
Great. No, I think that's a good addition. I think we'll try to do one more question, and Dr. Navarro, I'll kind of push this at you, and then we'll wrap up. And just a reminder, both the recording as well as other resources like the presentations will be shared after the event. I just have to get them online and stuff, so it may take a little while. But I think our last question, just for now, Janet asked what wildland firefighting work is highest risk for smoke exposure. Do you want to, I think this falls in your expertise, Dr. Navarro.
Yeah, so past exposure assessments for wildland firefighters have measured elevated concentrations of particulate matter, also polycyclic aromatic hydrocarbons, and carbon monoxide as well for firefighters performing holding. So kind of for the more public health folks, I'll explain it, but really walking up and down the fire's edge to make sure you don't have any fire getting out of your specified perimeter. So having spot fires. So oftentimes right along that active fire edge, and this can be smoky times. So mop up, so putting out of any extinguishing burning material, and then during firing operations. So when you're using also combustion of diesel and gasoline to set fire, so you're really taking away the fuel and burnable material between yourself, your designated
fire line and the active fire that is coming towards that line. So all of those are dependent on fuels and weather and a lot of other environmental variables that are hard to control. So trying to think about ways to possibly reduce time that you're doing those activities or finding better windows to do them if weather and conditions allow.
Great. Yeah, very succinct and good answer. Thank you. And I also want to point out that Dr. Navarro put some guidance on evacuation and cooling centers. That's another question that came up because obviously us and the sort of more general public have smoke exposure as well. We got a fire, I've been watching out my window here in Santa Fe. So that's a real threat for all of us. I think with that, we're over time and I want to wrap up here. Thanks everybody for participating, but particularly I want to thank Jason and Alex, Kat. John already had to leave, but you guys did an excellent job with your presentations. It was really better than I had hoped and I had high expectations. So thank you all. And I look forward to hopefully some of you will join us on future webinars. And with that, I'm going to close it all off. So thanks everybody.